I invite Dr. Mallika, to the professor of Ophthalmology Department, Medical College Trichy, for her talk on Introduction to the CVI.
Good morning, one and all. You must have come across a group of children like this. A child with light gazing, a child showing atypical reflex, and a child showing absent light reflex. A child with a history of difficulty in finding his toy and small prints. A girl with deranged depth perception. A child with difficulty in climbing up or down the stairs. A child adopting his posture to read the book in order to avoid his field effect. Child tripping over while walking. Do these children have cerebral visual impairment? That is what I'm going to deal with today. Cerebral visual impairment, as you know, is the deficiency in the function of vision. Something wrong with the visual pathways or processing centers in the brain, especially those posterior to lateral geniculate body. Eyes works fine, but the brain does not consistently understand or interpret what the eyes see. The occipital cortex is connected to other visual association areas to perform higher visual function through two streams. One is the ventral stream, which connects the occipital cortex to inferotemporal cortex and stands for the visual library or word pathway of brain, where prior memories of objects and people are stored and coordinated. The other is the dorsal stream, which connects the occipital, parietal, frontal, and motor cortex. It stands for visual map or visual space or word pathway of brain and helps to coordinate hand-eye movements on looking at a target object. So once you see such a suspected case of CVI, what history will you ask? You know that the hypoxic ischemic insult to the central nervous system is the major etiological factor in the CVI development. So these insults can occur antenatally, intrapartum, and postpartum period. So you should concentrate on the history of chorioamnionitis, antepartum hemorrhage, placental abnormalities, oligohydramnios, twin pregnancies, whether the mother had difficult delivery, prematurity, ROP, interventricular hemorrhage, and respiratory distress. Other causes of CVI are neonatal hypoglycemia, traumatic brain injury, congenital CNS malformations, CNS infections, hydrocephalus or a shunt failure, metabolic conditions, antenatal use of drugs like methadone, opium, benzodiazepines, alcohol, cocaine, seizure disorders, cardiac arrest and heart surgery, stroke or CNS tumors. So what next? What should be the suspected form of developmental history in them? If a child comes to you by 8 weeks with no eye contact, or 3 to 4 months with no social smile, by 3 to 4 months with no awareness of hands, by 5 months there is no watching of hand movements or any squinting, by 6 to 7 months there is no reaching out for any object, not recognizing faces by 7 to 9 months, by 9 to 12 months he doesn't point at pictures or pick up objects from the floor. By 1.5 years, he cannot put small objects in a container, does not point fingers when named, does not respond to mother's gestures and seems to be in her own world. By 2 years, he cannot scribble, does not seem to understand or follow simple commands, or does not walk steadily. By 3 years, there is trouble climbing up and down the stairs, does not communicate meaningfully, cannot eat without help. There is continuous drooling and unclear speech. When you see such a child, you have to suspect there is some amount of developmental delay. There are 16 areas of visual behavior affected in these children. The child may have a normal function, normal vision or a subnormal vision, but may have some of these visual behaviors specific to each child. We should know what is specific for each child, and accordingly measures are initiated to improve her visual function. Visual attention, they will have poor fixation and the gaze from one point to the other is very poor. Visual recognition, they will find it difficult to recognize familiar faces and places. Impact of clutter is great. They find it difficult to, their visual function is very poor if they are put in a very crowded environment. Usually they will have an inferior field effect, but it is sometimes the gaze will be fixed in right or left. Impact of color, they prefer very solid colors like red or yellow. Form accessibility is also very poor. Visual guidance to upper limbs and lower limbs, there is poor hand-eye coordination, and they find it difficult to crawl or walk towards a destination. Access to people, they find it difficult to recognize people, even the mother or the caretaker. Impact of light is dual. Some CVA children prefer a brighter environment to perform well, whereas some prefer a dark room for that. Response interval is also very much delayed. Impact of motion is also dual. Some people, some CVA children will prefer a static object, whether the other, on the other hand, some will prefer a motion object. Sensory integration is also very poor, and their performance is poor if with vibratory or auditory sensation. Visual curiosity for novel object is very poor in them. They can have nystagmus and squinting and gaze palsy, etc. So, how will you do the functional assessment? Is there any quantification method? This is more important for the early intervention specialist. Dr. Sini will be detailing more about this. According to the phase in which the child is presented, interventional measures are initiated. This is called CVI range. By a combination of observation, patient interview, and direct assessment, the examiner grades the child in 10 characteristics of CVI. These are color preference, need for movement, visual latency, visual field preferences, difficulties with visual complexity, need for light, difficulty with distance viewing, atypical visual reflexes, difficulty with visual novelty, absence of visually guided reach. So according to the phase in which the child is presented to you, interventional measures are initiated, and this will also help in the assessment of improvement in them. So what I would suggest is that there should be 3 must test objects to be kept in a pediatric ophthalmic OPD to pick up CVI easily. These are Lia puzzles and Lia mailbox. Either you can have the real ones, or you can even make your own thing with cardboard or a wooden thing which can simulate the same, which you can keep in your OPD so that you can recognize the CVI children and you can differentiate it from the OVA. The other object what I would suggest is the plus lenses, high plus lenses, +3, +4 or +5, because often we have seen that some children who fail to show proper fixation or follow movements, if you put a high plus lens, they will start showing some response. Usual ocular findings in these children are refractive error, hypermetropia is more common, accommodation dysfunction will be there, strabismus, exodeviation is more commonly seen than esodeviation. One particular pattern of strabismus is the shifting pattern, and they can have nystagmus, gaze palsy, and saccadic palsy. Optic disc changes they can have described are, one is the optic disc hyperplasia and the other one is the pseudoglaucomatous optic atrophy, which is more commonly seen in child with PVL. Whom should we order MRI? That also we should know. Any child with history of predisposing risk factors like birth asphyxia, neonatal hypoglycemia, neonatal seizures, STOMI postnatal cause, poor Apgar score, child with neuroregression later on, even if perinatal history was normal. So to conclude, time is crucial in diagnosing the leading cause of childhood blindness, cerebral visual impairment. While there is no cure, diagnosis and early intervention can unlock learning for these kids. These visual malfunctions can be easily overcome by simple environmental modifications, which can help the child to be a part of mainstream and help to perform academically and socially well. There is an acute need to create awareness about CVI in the ophthalmic, pediatric and obstetric community as well as the society in general. Thank you so much.
Thank you, Dr. Mallika, for the illuminating